Hi, everybody. Welcome to another question and answer session with Dr. Drossman and myself. Last week, we asked you to send us some questions that you might like us to answer live on our next video, and you responded quite nicely, so thank you so much. We have some questions that we're going to ask Dr. Drossman today. Dr. Drossman, how are you? Are you ready for some questions from our viewers?
Doing fine, and I'm ready. Go for it.
Here we go. So we had both patients and providers ask us some questions. The first one coming from a provider, and they ask, can Dr. Drossman speak to the functionality of the gut neurotransmitters and their role in this disorder, as well as their relationship to neurotransmitters in the brain?
I think what you're talking about is the substrate that defines the brain-gut axis. So we know the brain-gut axis is a connection, a hardwired system, so to speak, between the brain and the gut, because we have a central nervous system, which is the nerves in the brain. We have a spinal cord, and we have nerves in the bowel that we call the enteric nervous system. Millions and millions of nerves, as many as in the spinal cord. So that's the hardwiring. And they are connected because no other organ has that kind of connection, because there is a second brain that we call the enteric nervous system. Now, within the nervous system, in the brain or the gut, we have neurotransmitters and receptors. So a neurotransmitter is a peptide, a chemical, that acts on a receptor to achieve some type of action. Now, one of the really neat things about the brain-gut axis and these neurotransmitters and receptors is that they're very much the same. Chemicals like serotonin, norepinephrine, opioids are transmitters, chemicals that attach to receptors and perform different actions. Now, they can be the same actions, or that they can be different based on the location. Let me give you an example. You may have heard of cholecystokinin, which is a peptide or a hormone that contracts the gallbladder in the bowel. But in the brain, cholecystokinin causes satiety. So when you eat a meal, cholecystokinin rises, and in the bowel, it contracts the gallbladder, but in the brain, it could produce satiety, which makes sense. There are some very other interesting ones. CRH, corticotropic releasing factor, is a stress hormone in the brain. It's what responds to stress. But in the bowel, it's an inflammatory hormone, and we see that increase in people with ulcerative colitis and Crohn's disease. So these neurotransmitters have different actions. Now, there is as much serotonin in the bowel as well. There's 95% of the serotonin is in the bowel, and that's leading to gut functioning like motility, and it also feeds back to the brain in terms of pain reception. So in terms of your question, when we're looking at the brain-gut axis, we're looking at a hardwired neural system where the nerves connect. And in addition to that, we have neurotransmitters that can work together to establish actions between the brain and the gut, like pain, bowel movements, and the like.
Okay, great. So tagging on to that question, this one coming from a patient, and they're asking, saying, my doctor wants me to start taking an antidepressant for my abdominal pain, but I'm not depressed, just in pain. Will this really help to address my pain?
Well, that's a good follow-up question. So antidepressants, the term antidepressant, we know we're dealing with is a stigmatizing term. And that's why we changed the terminology to disorders of gut brain, to neuromodulators. I'm sorry, because as we said before, they're modulating the actions between the gut and the brain. And when antidepressants were first being studied, they were being targeted toward patients who had psychiatric problems. And we were treating the serotonin in the brain. And we basically used chemicals or drugs that increased the amount of serotonin or norepinephrine, which then helped treat depression. by repleting what was not present as much with these disorders. So it's almost like insulin and diabetes. There were actions that kept the neurotransmitters increased, they didn't get degraded, and the depression got better. But now, 40, 50 years later, we learn about disorders of gut-brain interaction, and we know that there are these neurotransmitters like serotonin, norepinephrine, dopamine, and so on, are neurotransmitters that act on re-regulating the brain-gut axis. And one of the basic ways it does it is pain. Now we know that signals that go from the bowel to the brain through the brain-gut axis are received by the brain, and then the brain can send down signals using serotonin and norepinephrine to block the signal. That's the gate control theory. So it blocks the signal, but in these disorders, it's not working that well. The brain is not sending down the right enough signal to do it. And so as a result of that, just like with depression, where you use antidepressants to replete these neurotransmitters, you're doing the same thing here. You're using serotonin and norepinephrine in particular to help send down signals that block the pain and reestablish normality in this brain-gut axis.
Yeah, that's great. And it's so effective. I can speak to that personally. All right, final question today. My doctor doesn't believe me when I describe how bad my symptoms are. He dismisses me when I try to talk to him about how they're keeping me from working full time. He tells me just to take Miralax and drink more water. How can I get him to listen and help me? A common question we hear.
Yeah, and I want to refer you, by the way, to our book, Gut Feelings, where we have a whole chapter on the items that you can talk to your doctor about. The heart of this question is in the question itself, because what you're doing is asking, what can I do to keep the doctor from telling me this? And that reflects the idea that the role that you're in is a more passive recipient of what the doctor is doing, rather than what we're trying to establish was what we call participatory care, or establish the doctor-patient relationship, where there's shared decision-making, shared listening, and so on. So when the doctor starts by being dismissive, the first item you need to do is to reflect on that experience to the doctor. Now, one of the caveats, when you give feedback, some of you have done this when you have fights with your spouse or with friends, you don't want to say, you're doing this. You don't want to put the other person as someone who becomes blamed, because that person will automatically get defensive and fight back. So what you want to do is reflect it on yourself. And what you could say, if the doctor's being dismissive, maybe saying, let's give me a scenario, be a doctor and tell me something you'd tell me if I were the patient, Johannah.
Dr. Drossman, I know you're describing the severity of your symptoms, but that happens a lot to men who are your age and have high stress job of a physician, and you just need to do some yoga and drink some more water. You're going to be just fine.
Okay, there are a couple of approaches that I can say to that. The first one could be, well, I hear you, but I'm not sure I understand where we go with that. I'm not getting enough information to really help me. I assume, Dr. Ruddy, that you're looking to help me, but how do we move that into something that's going to be meaningful? That's one approach. Another approach, which might be a little bit more direct, is saying, when you say that, I just want you to know I've heard that before from other doctors, and I don't feel like it's resonating with the way I'm feeling right now. And maybe we need to talk about it a little bit more, or maybe I can help clarify what I'm saying. So you see what I've done there, I've tried not to blame the person, but I've tried to participate by giving my feelings about it.
Yeah, that's great. And I think just to add on to that, if after you've done those things and you're still finding that there is not that engagement and that strong patient doctor relationship is just not possible, then in my opinion, maybe Dr. Drossman would disagree, but in my opinion, then it would be time to maybe seek a second opinion and find a physician who is willing to be a partner with you in your care.
I agree with that as the end game.
Right.
I think that there could be a process. You can do this in layers.
Yes.
So the first layer could be what I said, clarifying that we're not connecting appropriately, and I want to say more. That's the message. The other thing that could be said is this, as I said, this is not harmonizing with what I'm feeling. Can we do something more? So I'm giving them a second chance, saying maybe I can explain it better. Right. The third level would be more direct and say, you know, when you say that to me,
it makes me feel such and such. It
makes me feel not only not understood, but a little bit diminished. And I'm wondering if we need to address that. So that's before going elsewhere. And if the doctor still does it, then you really don't want to stay with that doctor.
Right. And as Dr. Drossman mentioned, all of this is outlined in our new book, Gut Feelings, with some tips and ideas to help you manage this, there you go, this complex relationship. So you can find that on our website, theromefoundation.org, or you can find it as an ebook version on Amazon for your Kindle as well. Also wanted to mention that next Thursday, the 25th, Dr. Drossman and I will be hosting a live author chat for patients and providers. And that registration is now open. I'll put a link to that in the comments of this video, and you can check that out as well. So thanks so much for sending in your questions. It was so nice to be able to answer them for you today. Dr. Drossman, have a great afternoon, and everyone, we'll see you next time. Bye-bye now.
Bye, everybody.